It features 4 speakers covering IT in a national perspective, the rollout in the Rural Broadband Initiative, or RBI, and its applications and potential in the rural sector. As you know, the bios are all covered on the app, so in the interest of time, the 4 speakers are Graeme Osborne, Dr. Andrew Bowers, Craig Young, and Becky Lloyd. Thank you, Graeme.
Okay, thank you. Thanks for inviting me to come to your conference, and looking forward to giving you a quick overview. Hoping a slide's going to come up in a moment. Do I have to do anything here to make that happen? He says, hopefully. Oh, excellent. So as you heard, I'm the director of the National Health IT Board. I've been doing this job for around 2.5, getting onto my 3 years. I want to just give you a quick heads up on the overall plan, because it affects rural as much as it affects the rest of the country. And I want to remind you that the National Health IT Plan is first about quality. All right, we're not out there trying to sell IT systems. We're not trying to get take-up. What we're interested in is information that supports a better quality outcome for patients and that has the trust of the clinicians who use them. And people may have seen me speak a couple of years ago, and I had this lovely triangle diagram that tried to show how we were going to get primary and secondary care to work closely together. Well, I'm going to show you where we move to now. So we've got an outcome statement, and it's based around a tree. But before I do that, just looking at the numbers along the bottom, that's the sort of numbers that I really enjoy. So does anyone have an idea what that might be? Oh, GP to GP in the front row, well done. So that's the uptake of GP to GP just over 12 months. So back in April a year ago, we had 92 transfers between GPs. And then just see how quickly it took off. And the reason it took off so well is the software we're getting implemented for these integrating tools is very easy to use. For all of you who are working in rural and primary practice, hopefully some of you have been using GP to GP. I understand that last month there were 14,000 transfers. And I think that's outstanding. And it just shows that if we work with clinicians and we have good products that fit with your workflow, we get take-up. So this is a triangle diagram. We've still got a vision that by 2014, New Zealanders will be able to access their health information. We've made huge advances in referrals. We're now going at 35,000 referrals every month, and each of the 4 regions have a referral solution. And Andrew's going to talk a little bit more about medicines. But what I really wanted to cover today is where's that going to end up? And this is the tree diagram, and if you had to sit down over a glass of wine or a sherry with your mother or grandmother and explain where's all this health information going to end up for me, this is the sort of diagram we find really helpful. And that is that if we start at the bottom, before we can start sharing health information, whether it's in an urban or rural environment, we've got to have the roots really strong. We've got to know who we are, who the patient is, who the clinician is, what facility and organisation they're working for, and we need to make sure that we understand people's ethnicity, maybe their alerts or other medical conditions. So that's what we're calling the foundational information, and in fact we go live with our brand new NHI replacement system in April, which will be a key part of that. The second thing we need to see in New Zealand is right across the country, we need access to what we call clinical results, or on the diagram, that layer there called common clinical information. So just like in Auckland, they have something called TestSafe, we're starting to see now in the Midland region, in the southern region, a growing access and availability of basic objective data, the results data, the medications, the radiology reports, discharges and referrals. The third layer we've got to get right is we've got to get the sharing of information to support continuum of care from the community environment that many of you are involved in, all the way through our secondary and tertiary hospitals, and then back again into the community. And we're continuing to put a lot of effort into that area, and you might have some questions about that. And then to cap it all off, the IT Board's very mindful that there are potentially around 10% of New Zealanders who have a long-term condition, or on the positive side, through things like maternity and other life stage events, are having an experience with our health system where they need lots of connections with different parts of the health system. And that's what the shared care plan concept is. So if you haven't heard, in New Zealand we will have one shared care plan available as a tool for everyone right across the country. and it's going to get rolled out on the back of the CPSA, the Community Pharmacy Services Agreement, and that'll get rolled out progressively over the next year. It doesn't take away from practice management systems or hospital systems, it's complementary to, and we can talk to you a little bit more about that. So when we look around the world, a lot of countries are still trying to put electronic health records as their end point. We've never wanted to do that. We think that that's a historical view and not overly helpful. In fact, on this diagram, the first two layers really are an electronic health record. It's the interaction of clinicians and their patients with their actual information around processes, around pathways, and on outcomes, which are the top two layers, which is the critical aspect we've got to get right. So thank you. Look forward to hearing some of your questions. I'm going to hand over to Andrew Bowers.
Well, thank you, everyone. I'm Andrew Bowers. I'm the Medical Director of Information Technology for the South Island DHBs and also specifically for the Southern DHB. So I cover all the Alliance activities in terms of health. First of all, I should ask you, why do we need to change? And I believe change is imminent and welcomed because we all know these. This is speaking to the converted somewhat, so I won't go through this, but we all know that there's changing population, we're all aging. There's limited resources and unlimited expectations. So let's have a look at what I think we need to do to try and address this. We're all aware that there are different parts of jigsaw puzzles that we're all working on. There's electronic medicines, there's notes, we'd all like to share notes across districts and regions. There's the need for a patient portal, there's need for bookings which are going to be consolidated and are simply able to be accessed from anywhere you are through any device and uniformly in a standard. We aren't there. We are working on these in part in silos, but there is something else that we're trying to do, and that's to put all these together into effectively a single package. In the South Island, we've rebranded this as Health Connect South, which is effectively going to be where I go to get things done for my patient. That will have access by general practitioners in the community, by mobile devices in the community, by the hospitals equally. So it's certainly a vision which is going to take us there, and it's going to be a long-term vision that's going to take several years to achieve. But the aim of this is to have patient-centred integration as opposed to system-centred, isolated repositories of data. So there's something missing here. Why haven't we got this now? And I'm going to talk to you about the current state because I think it's important. I'm going to flick through this, but at the moment in the southern region, the South Island, we have patient management systems, of which we have 8 for 5 DHBs. None of these talk to each other. None of these share information between them. Similarly, we have patient viewers or methods of accessing this in which we have multiple different methods, all of which have separate login requirements, although you can pass some across, and all of them are managed by separate companies, etc., and so on. And I don't need to read all that. But I'm going to start by being a little bit controversial here and say that the current patient administration systems we have in the South Island, or in fact right across New Zealand, work perfectly well for what they were designed to do. Now let's see, what were they designed to do? Because this is quite important. I think they were designed to be silos of information and they function very well for that. But that's good because we have no requirements to transfer patients between district health boards, between hospitals within the DHB. And that's fine also because we have, wrong button, we have no medical staff requirement to be shared between district health boards. That didn't move in the past. We didn't have any shared services, so we didn't need to move those doctors. And we had, of course, no requirement for one district health board to book into a service that sits in another district health board. We have no common reporting, but that's fine because we had no shared intelligence between them. And in fact, that's fine also because we have no shared vision between the district health boards. Times have changed. Let's get rid of all this and start with a blank sheet again. I just want to talk to you about some of the flights that I'm doing lately, and I think this is quite a good analogy. So try and think of analogies here as I push this through. The Air New Zealand model. The other day I flew from Nelson to Dunedin via Christchurch. So I was ticketed for the whole journey in one place online, one shared record. Each airport along the way knew that I was heading for Dunedin and knew that I was coming and knew that I was on a plane. Seating preferences followed me. I had one bill, even though I covered 3 airports. It was coordinated departure and transfer and arrival times, and my luggage came with me without having to actually go out and pick it up, and they knew where to send it. Let's have a look at the health journey. If we're talking about a patient's health journey, it's just a bit different, isn't it? I think you know this. So it started off, of course, you can't send somebody away unless you've actually coordinated the arrival beforehand. So you actually need to do a discharge summary, but you need to phone somebody before that to get that. So they've got to give the paper documentation to the patient. I won't go through this. You can see this. It's just a mess. There is no coordination between the district health boards. Well, there is some, but it's not all it should be. Now that we're working more towards regional shared services, it's very, very important that we get this right, that we coordinate care and we transfer information between general practice, between hospitals. We don't transfer, I should say, we share that information. Now, you wouldn't accept this from your bank, would you? You wouldn't accept this from your Air New Zealand. You wouldn't accept this from any other company, telecom, Chorus, anyone that you get your bills from. So let's have a look at perhaps a new model of way of thinking, in which there is a patient administration system. Isn't really a patient admin system as we've become used to it. We should be thinking in terms of regional data, in which we have a patient-centred clinical view of that data, but also we have the ability to put all our electronic prescribing information onto that, so that we can access it from wherever we need to access it. We can also take out of that information, data, to make it into information to share intelligence about the way our region is performing. And actually, even taking that further, we should actually be able to have real-time dashboards to show how we're actually doing in real time. Emergency department vacancies, time to get onto the ward, we can actually share that between DHBs. In fact, we can then make plans to design our health system. But of course, we can't get away from the need for basic hotel services, but that should also be pulling and pushing out of this regional data. And in fact, we have to, of course, bring into this the patient portal. Now, we have a mandate to go ahead with similar processes, and I'm very pleased with that. We also have to take that the next step further. Each of the four regions in New Zealand are looking at this in their own way, but the longer term plan, of course, is that we have national linkages for this data, so that we can share information between regions and with other important groups, of course being anonymised and all for importance of health delivery. I call this really the keep information system simple principle. So what's in IT for me? I believe that in the next couple of years we'll be able to offer a single clinical portal for all information. And I really mean this. What it means from a clinician, I can go from Dunedin Hospital to Christchurch Hospital, do a login with the same login and get information about where I am and related to my clinic. Sitting in a general practice, you should be able to do the same. You should have the same link to it, to the same information that we all view at the same time. So there isn't a list for you, there isn't a list for Christchurch, there isn't a list for Wellington, there is the list for the patient, and it is patient-centred. And enable transparent sharing according to your role. In other words, security is a very important part of this process, and your role limits your access to that. And this one, last but is a completely unashamed, come and see me tomorrow, where I'm going to talk about electronic medicines management and the Go for Gold campaign, and really how this is going to fit into the larger picture. We've a very short time to do this presentation, but I will welcome questions afterwards. Thank you.
Kia ora, good afternoon. My name's Craig Young. I work for Chorus, which is a brand you probably see around your towns and villages quite a lot on the side of vans. I would expect that you probably see some vans on your way home tonight, actually. I was trying to figure out a link between the discussions you just had from Graeme and Andrew, and I can give you a little story. We moved within Auckland just 2 years ago. We moved doctors. We had to take hard copy medical records with us within the same district health board at that point. My son and I both went overseas last year on different trips to different continents. We both had to go to the travel doctor. He had to fax the district health board to find out whether my son had had his the shots they have at school. And so, you know, we have first-hand experience in our family on moving between medical professionals and not being able to share the information. So the link, I suppose, is that I get to work for an organisation that is delivering the pipes and the tools that will enable all this exciting stuff to happen. And that's probably a little bit of a shift here for a moment between all the exciting things that Graeme and Andrew have talked about and Becky's going to talk about. Besides, she works for a very I say sexy mobile company, but they're actually much more than a mobile company these days and a very important customer of Chorus's. So many thanks for letting us speak this afternoon. I do want to take a moment and introduce Chorus. Chorus is New Zealand's largest telecommunications company. It's listed on the New Zealand Stock Exchange. It is separate from Telecom. We were split from Telecom in December 2011. We are no longer part of that group at all. In fact, they pay us real cash every month for the services they buy from us, and they remind us of that every day. We connect to 1.8 million New Zealand homes and businesses. That is, I would hazard a guess that every one of you in this room has at least an old copper telephone line that comes into your house and you have a phone service that somebody such as Telecom or Vodafone provides to you. But that's our piece of copper that provides that service. We have about 650 staff that work for us. That's permanent full-time staff. But we have these vans, 2,000 service technicians and 1,800 vans across the country. You'll see a picture there at the top there. They're white, they've got blue on them, you'll see them. And now that we've talked about it, on your way home, when you leave here, you will notice them. And they work for our partners down as Transfield and Vision Stream. So sorry to take a little bit of a shortcut there, but I'm fine that most times I need to remind people who and what Chorus is. The other thing I should mention is that we do not sell services to end users. So it's no good ringing Chorus and asking for a service. The way we're set up, we are a true wholesaler. So it's a little bit tricky to try and come to an event like this and try and encourage you to come to Chorus, because basically you already are with us. But we want you to take the new sexy stuff. But we need you to talk to people like Vodafone, like Telecom, 2 Degrees, all of those customers. Telstra is about to go. Yep, okay, Vodafone Fixed New Zealand Limited. And your service providers, Bay City, even though they're a satellite provider, are still big customers of ours. So we need them to be talking to you and you talking to them about the sort of services you'd like. I want to talk about RBI, the Rural Broadband Initiative. This is all about improving broadband into rural New Zealand. We won't go back and talk about whether there was an underinvestment previously, but the government decided they needed to put some money into rural broadband. And so they've taken 300 million of the industry's money and given it back to us to actually spend on rural broadband, which is, I think, one of the most exciting things. You know, the government's spending $1.3 billion on urban broadband, but rural broadband is where I think the excitement lies. I want to be quite clear, there are 2 contracts under RBI and 2 complementary contracts it is. One is Chorus, which was done previously with Telecom, but now it's ours. And that's the school's priority, and I think that's an amazingly exciting story. We're going to deliver fibre services to 1,039 rural schools in New Zealand. They will have exactly the same fibre fast broadband services as any urban school does. So no longer will the rural schools actually be left out. They will get exactly the same. And as part of that, we're upgrading the cabinets around the place, about 1,200 of them, to give you faster broadband. In fact, quite a few of you have already come and seen me at my stand and asked when you're getting broadband. We put your name into the address finder and found out, and in a month's time you'll have broadband at your house that you didn't have before. So those sorts of stories are really happening. And if you want to know what's happening around your community, around your area, please do come and see me at the stand, and we'll talk to you about that. Vodafone are building 154 new towers, and we're providing fibre to every one of those towers. And Becky can talk about what they're doing. But I think the other thing I want to mention today is that we are delivering fibre to hospitals. We contracted to deliver fibre to 51 hospitals, named hospitals in New Zealand as part of the 2 rollouts. And I do have that list with me. But there are another 270-odd rural health centres which we're not contracted to deliver fibre to, but if we go past your front door, then we are obliged to be able to offer you a fibre service. Now, I say obliged because that's the wording of the contract, but of course we'd love to give you fibre. So another thing that happens, again, you've got to go back to your service provider, but we'd love you to be talking to your service provider about the types of services you can get into your health centre. Because, quite honestly, if you're going to make use of the services that Andrew was talking about, you're going to need access to this wonderful thing called the cloud. The cloud is not in your server room, it's somewhere else, and you need a fast pipe to get to it. And so we want to be able to provide that for you. I would just finish off by saying 2 other things. RBI doesn't solve all of rural broadband's needs. We are completely aware of that. It only runs to 2015 anyway. We as Chorus, as a New Zealand company committed to rural New Zealand, are looking at ways of working with all the internet providers that are out there, including the wireless providers you get in rural New Zealand, to see if there are innovative ways that we can work together as an industry to actually deliver fast broadband further and further out into the hinterlands of New Zealand so that everybody can actually get access to broadband. So that your local GP that is in a small town in Rotorua, for example, I was looking at this morning, we've got fibre going past their front door. We should be able to provide them a service that links them to the rest of the world. Finally, I'd just like to say thank you to Dr. Joe. He's actually on, there is a national advisory board that's part of RBI, and he represents your interests incredibly well in that national advisory board. So thank you for your time today.
Hi everybody, I'm Becky Lloyd. I'm apparently from the sexy side, I'm from Vodafone. I'm going to talk to you a little bit about the mobile part of the Rural Broadband Initiative and why Vodafone is so passionate about what we think RBI can do for rural communities in general and for rural health in particular. I do have a little bit of a personal interest in the health field because I grew up as the daughter of a GP, and I grew up before mobile phones were invented. So my teenage years were spent with the fixed landline in the hallway on the phone to my friends. But because my mum was a GP, whenever my mum was on call, I wasn't allowed to use the phone. So the day when she came home with one of those first mobile phones that were about that big was a really big day in my household, because that was the day that I was allowed to get back on the phone and talk to my friends. And I think ever since then I've had a little bit of a passion for communications and how they can help improve the effectiveness of businesses in general and health practitioners in particular. Anyway, Craig mentioned already that we are in partnership with originally Telecom, now Chorus, for rolling out the Rural Broadband Initiative. And what that is delivering, as Craig mentioned, is on our side, improved mobile coverage and reach across rural New Zealand. And it also specifically delivering this service called wireless broadband, which is designed to reach the places that fibre and fixed lines can't reach. So the two are complementary services, and they sit on top of one another. And when we've finished the rural broadband rollout, which is a 5-year programme altogether, and we're a couple of years into that, we will have delivered mobile coverage to an extra 6,200 square kilometres of New Zealand, which equates to an extra 4,000 kilometres of New Zealand roads, which is going to be great for people who live in those areas. As Greg mentioned, there's still a further 3% of coverage that we have to work out how we reach, but in the meantime, what we're doing is making a big difference to New Zealanders. And it's going to benefit 250,000 extra New Zealanders who don't have mobile coverage today, which is fantastic. And it's all about, as you will know, bridging the digital divide, as it's called, in more political spheres. And the reason why we think that's important is because we believe that a connected community is a stronger and healthier community. And I'll talk a little bit more about how we see that working. So Craig mentioned schools and fibre to schools. It's a really, really important area for us to address. Pupils in rural schools need, and they have the right really, to have access to the same educational facilities as kids who go to urban schools. And so we're working with a number of schools to look at how we can provide those educational resources and access to those educational resources in the classroom. The other thing that's really important is that you probably know that kids are starting to use tablets in schools, and teachers are starting to involve kids in e-learning. And we believe that as kids leave the school gate, the educational process continues. So it's important that when they go home with their tablets, that they're still connected, they can still get mobile access, and they continue to tap into the resources and into the cloud that Craig was referring to, so that they can continue to learn. And we're currently trialling that with a couple of rural schools in the Canterbury area to see how that works in the field. Second important area is agribusiness. And of course, agribusiness is really important, 70% of New Zealand's GDP. And we're finding certainly that farmers in particular are among the first to take advantage of this better connectivity. So for example, did you know that the fastest growing segment on Trade Me is agribusiness? So farmers are now taking advantage of the faster broadband access that they have, and they're using that to deal direct, probably cut out the middlemen and save themselves a few dollars in the process. They're also really embracing the world of apps. So there's a huge explosion in the number of apps in the field of agribusiness, things like animal ear tagging and tracking your herd. And you may have been to some fancy restaurants, perhaps overseas, where you order off the menu and it tells you the entire life cycle of the piece of meat that you're about to enjoy. And farmers who can track and demonstrate the provenance of their livestock are able to sell and charge a premium to these fancy restaurants. And that's actually going mainstream. So I was back in the UK. I'm from the UK, as you can probably tell. I was back in the UK in January, and I noticed that Waitrose, which is one of the slightly higher-end supermarkets in the UK, actually is labelling their meat with the entire life cycle and where that particular cow might have enjoyed its calfhood in the rolling hills of the Waikato, perhaps. So food tracking, but also more prosaic applications like legislative compliance, complying with effluent management and water and so on. So the farmers are getting in on the game as well. Households, equally important. The urban population, as we know, is growing, and that's causing quite a few congestion areas. I'm living in Auckland, it's quite congested. So the ability of people to move into less populated, more rural areas is enabled by having better connectivity. And it actually helps people to employ, as I'm sure you find. It's easier to employ people if you can assure them they're going to have great connectivity to the wider outside world. But we're here really to talk about health. So what are the applications around health? Well, Vodafone has a practice which is called mHealth. The M stands for mobile. And it's really a practice that's a worldwide practice where we're looking at areas where we can use mobile capabilities to improve the health outcomes of patients. It has two real benefits. One is it reduces the cost to deliver healthcare, but two is it improves the actual outcome for the patient, the quality of life for the patient. So a couple of examples of that. One is this remote monitoring or remote care services. And you probably have heard some of these kinds of applications before. It's where a patient can be monitored in the home, and all sorts of health conditions this can apply to. And that patient, therefore, the stats and metrics about that patient's condition can be sent back to their community health worker, whoever's looking after them. It means that if there's a problem, if their results start to go a bit worse, they're showing more symptoms, that they can be then acted upon really quickly. It saves cost because it means and it saves the patient's time because it means they don't have to be constantly going to the clinic or the community health worker constantly going to see them. And of course it improves the patient's quality of life because they're able to be cared for or looked after at home rather than having to go into hospital or into clinics. So it's really a win-win solution. We're starting to see that kind of solution proliferate all around the world. Secondly, there are benefits around faster diagnosis. So Craig was talking about higher bandwidth. And actually, so the example that we just saw with connecting with the Cook Islands, you can imagine that patients' scans and so on can be faxed to an expert, communicated, faxed is old school, communicated to an expert on the other side of the world. And we're starting to see other applications like Follow the Sun, so clinics that are open at midnight here, daytime over in other countries. So all of those kinds of capabilities mean that patient care and diagnosis can be improved massively. Other areas where mobile and mHealth can help, there's things like lone worker applications, and these kind of came out of more urban areas. So social workers in deprived parts of London, for instance, use a solution which is a lone worker solution. And effectively, if they feel they're in danger or threatened, they can trigger an alarm, a discrete alarm, and then someone can come in and help. Same thing can apply equally if someone's in a remote area, a rural area, and they're seeing a patient in an area on their own, and they need some sort of fallback or alarm capability. We've already heard about mobile medical records. So you may have seen recently that we've just been selected to provide services to the New Zealand Police Force. They'll be able to access citizens' criminal records, hopefully not patients. And in real time when they're out on the field, you can see exactly how that would apply to patients, and it would be much more efficient and effective for community healthcare professionals to be able to access patients' information when they're out in the field. Saves that calling back, exactly the example that Craig was giving just now. And of course, last but not least, emergencies. So being able to contact and call on help in the event of an emergency. So all of these are areas where we see that the Rural Broadband Initiative can significantly help to deliver great healthcare into rural communities. And overall, the reason Vodafone is so passionate about the Rural Broadband Initiative is because we firmly believe that improving connectivity and access will improve and deliver healthier communities across New Zealand. Thank you very much.
Thank you very much to the IT panel. It's great to see the sharing and networking going on at the IT level from everywhere from the hardware right up through to clinical applications. We do have 5 minutes, please, for questions from the floor. So I'll open up the floor. Please raise your hand. Someone will come to you with a microphone, and you can question away. Bear in mind that Andrew has got his session on tomorrow as well, and you can catch him there. Down the front, please. Thank you. Down the back to start with. Got it.
Kia ora, my name's Lydia Martinga. It's for the second speaker. It's in regards to your talk about the portal and how that was going to happen. Is that going to be just specifically for DHB to DHB and ministry to ministry? Is there any intention of it going out to NGOs at any stage? Thank you.
Thank you. I think that there's several answers to that, and I don't want to fluff it at all, but I think that the aim at the moment is to build the infrastructure that supports a portal from various different options. So there may be different portals in different regions, but the intention is that it's for the patient to access, in their own time, to access a limited component of their records. For example, their medication list, health information which has been provided for them on those medications or on their specific conditions, and will be, at least in most cases, will be available as part of a shared care record view where you can have input into your health as a patient. And remember, we're all patients as well, I expect too, so there's value in it for everyone, not just for the doctors. But the intention isn't that it would be a DHB to DHB hospital communication tool at all. It would be for everyone in the community.
Thank you, Graeme.
Hi, kia ora, Graeme Jelly, I'm a rural GP. Andrew, just the concept of a central data repository as opposed to a system that can glean the appropriate level of information from a disparate set of databases. Do you have a preference on that or a comment on that?
Can I ask that infrastructure question to be answered by Graeme, please?
It's an excellent question, and in New Zealand we've gone for a hybrid model. So you saw my layers that I presented in the tree, and we went for a hybrid for a very particular reason. Each of those layers has a clear owner. So either a general practice or a DHB or the ministry owns each of those layers, and therefore they have a accountability to make sure that layer is always on and always high quality. What we need to ensure is that wherever you are as a clinician or patient, you can get to those other layers just one click away. So the idea is there won't be a national data set for all health information. We see that as not a useful model, but there will be a series of regional and local data sets that will know about each other and will enable you one click to be able to get through to the information you're looking for.
I call it a functionally single database set, but it's got lots of bits of tin behind it.
Campbell Murdoch from East Otago. I worry about the guardianship of this data. I once had a situation in my own family where one of them had gone to a doctor and felt dizzy, and the doctor put query MS in the notes, not electronically. But several years later, when she turned up for to get a mortgage on a house, it was demanded that she have an MRI because someone had suggested she might have MS, which was only a suggestion that had no kind of reason for it whatsoever. And I guess the real issue is this issue of, with all this potential data that's being put into the cloud, how do we how do we guard that in a way which is, it doesn't do damage to people? You know, it's a real, seems to be a real potential. I mean, given the fact that in my practice, less than 5% of my consultations are referred to secondary care, about 1% of these are acutely. So you know, 95% of what I put into the cloud is totally divorced from that. And there's kind of issues around what happens when all of that information is available. I mean, I shudder to think how I would deal with it, but I equally shudder to think how patients are going to deal with it.
So here's the good news. We're not putting all that information together. And that's my point about a hybrid model. What we're doing is we're asking, in your case, GPs to manage the information for you and your patients and to offer a portal as an additional service when you're happy to. So GPs are going to have to become confident about how to do this. Now, we've got an excellent set of examples that are occurring in New Zealand. Dr. Richard Medlicott in Island Bay has over 3,000 patients on a portal access. Now, none of the information that he puts in or the patients put in end up anywhere near Wellington or the DHB. What happens is a summary of the problem list and the medications ends up with the DHB, and it is only there for use for after hours and for ED access. So this is what I mean by a hybrid model. It's got a cascade. And I think the very first word you said is the correct word, governance. Who's going to provide, or guardianship you said, but guardianship governance, and who's going to provide that? And so our model respects the fact that general practice has a wellness model with their patients where the vast amount of information that transfers between a GP and their consumer is not needing to be available for others. But at the point that a referral is needed, or at the point that someone appears at an ED or after hours event, then some information is valuable. And we're very mindful that it is only part of the information set that is made available in those other settings. So we could spend all afternoon on how we're doing that, but just to give you an idea, we run workshops like this here. We have town hall meetings with consumers, and consumers have been very clear. They like us sharing objective data. They like us sharing medication lists. They like us sharing radiology reports, lab reports. They don't get excited about us sharing the notes that are written down in detail between a GP and their patient. They just want the data that is of value for the next clinician or health worker at the time when they're meeting someone for the first time. So there's a lot of thought going into it, and this is why we're not putting all the data into one place.
Thank you very much. Time quickly for one last question, and then we will move on. Thank you.
Kate Baddock, GP in Warkworth. We've been looking at the cost of putting in patient portal. We have a practice for over 10,000 patients. And the cost is somewhat prohibitive for a practice to entertain. But I understand that there is a drive from the National IT Board and elsewhere to certainly encourage their patient portals to happen. I'm just wondering what plans you have to incentivise general practice to go down this route.
So I can give you a very easy answer. There are no plans to incentivise other than a nice arm around your shoulders to say, keep going. There is a reason, and it goes back to Richard Medlicott again. This is your business, and the way you introduce patient portals is something you've got to think through very carefully. What we are happy to do is we're happy to talk to the vendors and make sure there's competition and there's options and you don't get forced into one vendor and one price. So I would ask you to get in touch with us because we can influence the vendors and how they put forward their options to you and to make sure you're looking at all the options because not all the options are highly expensive. The last comment I make, and it's a general comment, is even in an urban environment, and maybe it'll be different in rural, you'll fill me in, I'm sure, only around 10% of patients, and this is around the world, are taking up the option of a portal with their primary healthcare provider. So 10% is not very much. Now, I'm sure in 30 years' time, when all of the digital natives are alive and kicking and wanting support, it'll be larger than that. But at the moment, a lot of people are saying the health information is for the doctor to manage and the medical side of the sector and that the patients are happy for that. So my test for you is to talk to us. We'd love to see if we can help, but more importantly, target your patients that you think will get the most value out of it, because it takes time for them and for you to make this work.
Can we please thank the IT panel once again?